This is a presentation that I gave at the 2019 MSRT annual meeting. It was originally 100 minutes long. I've broken it into 4 modules to make it more palatable for an online audience. This is Module 3, and it contains material that reviews the function, construction, and history of collimators and collimation. Here we will deal directly with the topic of collimation. You will find that these principles have not changed much in the last 100 years. Collimation has the same effect on patient protection and image quality in the digital era that it did in the film screen era. When it comes to patient protection, avoiding repeat views is still the most effective means at our disposal to minimize patient dose. While collimation can be the cause of a repeat, poor positioning and centering are still a more likely reason to cause a repeat. Observe the image on the right. What are the 2 obvious problems? I'll give you a minute to consider your answer. If you answered that it is off-center and the costophrenic angles are cone-cut, you are correct. Here is an example of the previous radiograph repeated with centering and collimation corrected. While this is an acceptable image not needing a repeat, collimation could be tighter. While the previous image was acceptable, to collimate to this degree takes experience and a high degree of skill. Grids add to patient dose. Knowing when to use them and when not to use them can benefit your patients. MAS controls patient dose. Double the MAS, you double the dose. MAS also controls the number of photons striking the image receptor. Use too few photons and you'll cause quantum mottle, a grainy appearance in the final image. The use of higher kV and lower MAS techniques benefit patient dose to a point. Contrast is not adversely affected by kVp like it was in the film screen era. The 15% rule still works and can be used to swap MAS for kV. Here we have 2 identical patients, except for the patient on the left is subjected to tighter collimation. When exposed, the patient on the right produces a large amount of scatter. This scatter fogs the image, reducing visibility of detail, but also increasing the dose for anyone assisting in the room. The patient on the left produces significantly less scatter, with fewer bad side effects of that scatter. The patient on the left benefits from tissue sparing. These tissues and organs are not exposed to the primary beam. The primary protective effect of collimation is that it restricts the volume of tissue exposed to the primary beam. This can make a significant difference for sensitive tissues or organs like bone marrow, reproductive organs, or even the thyroid gland. Scatter degrades the image and contributes to a higher dose. Fog contributes to a significant loss of contrast that the computer needs to differentiate tissue boundaries. This loss of contrast can contribute to a loss of visibility of detail. Scatter radiation not only benefits the patient, but also reduces technologist dose. Our primary source of radiation on the job is scatter emitted from the patient or devices in the primary beam. Fog is also called noise. Keeping the signal-to-noise ratio as low as possible aids the computer's efforts to accurately reconstruct the image. Just a word of caution. Collimation is the one geometric change that does not affect detail. Collimation does affect the visibility of small details, a very different thing. Here is a chart that illustrates how tissue volume decreases with field size. I arbitrarily set the patient thickness to 22 centimeters and charted the common field sizes. Notice how that at 50% field size, the volume of tissue exposed to the primary radiation is reduced by 50%. And that equals a 50% reduction in dose for that particular view. Now let's look at the evolution of collimation and the methods of affecting collimation. Here is an illustration of a PA hand being radiographed more than 100 years ago. Notice how much collimation is in use. I'll draw a circle around the X-ray tube. If you answer the tube is exposed with no collimation, you're correct. While this is not necessarily the standard, many early radiographers practiced in this manner. Next, I'll draw a circle around the man being radiographed. Finally, any idea what this man is doing? He's monitoring the exposure using a crude fluoroscopic image of his hand. During the 30-minute exposure, you may see him adjust the generator up and down depending on the image he sees in his fluoroscope. It was soon discovered that restricting the beam improved images which were badly fogged. So a crude form of beam restriction was added to X-ray tubes. The lead glass bowl surrounding this X-ray tube was added as a crude form of collimator. Notice it did little to stop stem radiation not directed at the image receptor. Here is a tube gantry and collimator seen from a few feet away. The earliest collimator was nothing more than a lead sheet, with a hole cut in its center. This early collimator was called an aperture diaphragm. Later on, a long cylinder was added, moving the point of restriction away from the focal spot. This would further reduce off-axis radiation and improve the image. The sight line of the cone would also aid the radiographer in centering the cone to the part or the cassette. If radiographers needed to cover a larger field, the cone could be flared. One problem shared by all the previous forms of collimation was that the cone or aperture diaphragm only worked in one situation. To vary the field size meant that you needed to have separate devices to fit each situation. As nearly as I can tell, the double-leaf collimator was developed in the 1950s. These devices made field size infinitely adjustable and added a light to aid in centering and viewing the field size. In addition to needing an aperture diaphragm to fit every situation, they had one other problem. Aperture diaphragms suffer from beam undercut. Surrounding the collimated field is a fuzzy area. Beam undercut is akin to reverse penumbral shadow projected onto the image receptor. Since the aperture diaphragm is close to the focal spot and far from the image receptor, it tends to be very large. Aperture diaphragms are still in use in dental equipment since they use one film size and they don't need the adjustability that we do. As I mentioned earlier, one way of reducing beam undercut is to move the point of restriction away from the focal spot. This can be accomplished by adding a hollow metal cylinder to the aperture diaphragm. Note that the point of restriction has moved closer to the image receptor and that beam undercut is reduced. Probably the last widespread use of flare cones was in xerographic mammography. The cone was used to not only provide collimation, but also provide breast compression via a balloon placed in the collimator's opening. The final evolution of beam restricting device was the double-leaf collimator. Due to my limited artistic ability, I will only show you the longitudinal leaves. This is the first upper set. Now the lower set. Finally, here is the path of the edges of the X-ray beam. Notice the bottom leaves catch the beam undercut, virtually eliminating it from the image field. Since aperture diaphragms are a sheet of lead with a hole punched in the center, that makes them inexpensive, easy to produce, and there are no mechanical parts to fail. Since you need multiple aperture diaphragms to meet different situations, they are often easily misplaced. They suffer from extreme beam undercut, and finally, they are difficult to align with the patient image receptors or anatomy. Cones reduce beam undercut and are easier to align with the patient's anatomy. You can sight down the length of the cone and obtain a rough idea of the path of the central ray. Cones are difficult to produce and can be damaged if dropped. They share the problem of needing multiple shapes and types to meet different situations. Double-leaf collimators eliminate beam undercut. The collimator is permanently attached to the tube, and a single collimator replaces a whole rack of cones or aperture diaphragms. Finally, collimators include a light beam localizer that aids in centering and field adjustment. Collimators are electromechanical devices, so they are expensive and suffer from breakdowns and misadjustment. Registration of the primary radiation to the light beam localizer needs to be checked on a regular basis. This ends Module 3. In Module 4, we will look at the specific effects of collimation on digital systems. Thank you.